speech, and I would like kindly request the speakers to come on the panel and answer our questions. Yes, please, Mr. Zelos.
One question. There are a number of patients who refuse any type of treatment. They will refuse dietary modifications, exercise, surgery, even medications. Is there some unusual hormonal aspect to that? There are hypersecretors in some of the proteins that you, the hormones that you mentioned. What's the data on that?
We see some of those patients who are very resistant for any interventions towards the kind of bariatric problems, but I'm not aware of any of this data. But my own experience comes, and it's not only from the UK, Gulf, UAE, Saudi, Egypt, is that a lot of these patients are the patients who are following the social media. So basically they go on social media and then they'll find someone who's saying, oh, surgery is going to kill you. Or there is a new trend now coming and saying that GLP-1 agonists can cause intestinal ischemia, it can cause this, it can cause this, so just be careful. Unfortunately, in the current DNA that we live in, we see that about 70 to 80% of what we see on the social media is not scientifically correct. But somehow it reaches the patients. And this is when patients become very reluctant to even listen to anyone. But it's a shame that this is the time that we live in. But I'm not aware of any data for any kind of hormonal kind of problems that might just affect the way they think about surgery or medications. Thank you.
Sorry, did you ask about non-responders to medicine?
People who refuse any type of treatment, they will refuse any type of intervention, and the question is whether they had some sort of hormonal, extra-hormonal secretion, anything that is making them refuse any type of treatment. That's all.
Thank you very much. Any other question? Yes?
Hello, excellent topic. We saw 3 times a global map, and it shows in some countries, thank you, in some countries, obesity is like an epidemic. What do you think that helps other countries not have this problem? Is it because of lack of food? Is it because the quality of food, they don't have junk food or whatever? Is it because social reasons, I mean, they don't eat so often or whatever? Is it because of genetic reasons? What do you think?
Mostly, I think it is genetic. There are some behavioral aspects there, but mostly it is genetic, in my view.
Yeah, I agree. I think it's genetic. But what we have found that it's not only genetic, it's also epigenetics. So that these are the genes that can be modified by the lifestyle and then the current environment that we live in. We've done lots of research on this, and we find that there are regions where, yes, genes work in the background, but also because changes in the lifestyle, changes in the type of food we eat, changes of the pace of life that we have. This is when a generation after generation, they will find that there's a trend towards having obesity. Yes, I agree with that. Yeah.
Any other question? Yes.
Very nice presentations from all of the 3 doctors. I just wanted to comment or ask whether, I mean, having other options like endoscopic balloons, ESGs, TORs, or everything is going to make more people come into the obesity treatment, because it's not, I'm a bariatric surgeon, I would prefer to have sleeves and bypasses and all that, but generally speaking, if you have more options, because we start reoperating now, guys that are 20 years old, 25 years old, and they had the first sleeve or the band, and now they have the sleeve and then they have the bypass. I mean, if we put more options to our table, maybe it's going to be better for the patients and also better for us, because we don't really want to have someone 40 years old having had a duodenal switch and failed, because what are we going to do next?
Yes. This is a very excellent point. It's an excellent comment. Now, after years of doing bariatric surgery, the way we think about obesity now is just it's a very long journey. So in the past, when I started doing this, or when I was being trained to be a bariatric surgeon, I'm talking about 2000, 2001, the belief at that time is that we're going to have the patient, we're going to have one procedure, and at that time it used to be the gastric bypass, that's going to work for the rest of the patient's life. As time passes and as we've seen the results, no, it never happens. So every patient will have a journey through which he will have multiple interventions. It's extremely unlikely that the patient will have a procedure, whether a gastric bypass, sleeve, switch, whatever, that's going to work for the rest of his life. Yes, this patient exists, but I don't think that they cross anywhere beyond 20% of the patients that we see. And this is when we started thinking now, fine, it's going to be a long journey. So I'm going to see a patient who is 20, 30, even 40 years. So he's got another 40 years to live. So he'll probably need multiple interventions. And that's one of the reasons why, for example, now we think that a sleeve is a very good start. Because that's going to take him for probably 7, 8, 9, 10 years. And then after 10 years, when he starts to regain the weight, when he starts to develop diabetes, then we can perhaps convert it to a mini gastric bypass. It's going to make them lose weight, give them another 10, 12 years. And when they become diabetic or anything like this, we might think about another alteration of the mini gastric bypass or start GLP-1 agonist. And this is how we're going to get 10, 20, maybe 30 years before starting to develop diabetes, and we're going to declare fine failure. But at the time, the patient's age is not going to be 30, it's going to be 60, 70. So I'm very happy. I'm a person who would be very happy to get diabetes if I'm 65. Because if I live another 20 years, by the time I get all the microvascular complications of diabetes, I'll be in my 85. So if I'm going to die from the heart or from the kidney failure or from this and that, fine, it's my due time anyway. Now, coming back to your very interesting point about the new interventions in managing obesity, right? Whether it's endoluminal, GI, or it's balloons, or it's the stitching of the stomach, what they call duplication, or any of this stuff like endobarrier, In the era that we live in, where surgery is extremely effective, drugs are extremely effective, I very much doubt the benefit of any of this stuff at the moment. Because how it's being sold now that, for example, endoscopic sleeve gastrectomy is something that takes about 20 to 25 minutes with an endoscope, non-invasive, completely outpatient, works. It does work, but only for a very short time. Because no matter how you do it, you still have left the ghrelin secreting part of the stomach, for example, so the patient still feel hungry. So all what you've left them with is limitation of the capacity of the stomach. So you just reduced the size of the stomach.
It's not a metabolic punishment.
So it's not metabolic. So it's basically purely restrictive. And this is why we see a lot of failures after that. And this is why even the most competent endoscopists who are offering endoscopic sleeve gastrectomy or ESG are now coming to present in all of the meetings, coming and saying ESG plus tirzepatide. And this is how they can achieve a really, really good weight loss. And the same goes into gastric bypassation or kind of endoscopic stitching stuff. They don't work on the physiology that we spend the last hour and a half talking about. They talk about something that it's minimally invasive that is going to make the patient lose weight. And I agree, they do work, but only for months, not even years. And you will have to do something after that. So far, I don't think that there is a minimally invasive technique that has been offered to patients to lose weight that works for a long period, unfortunately. And this is when I'm just guessing that are we moving into the commercial side of treating obesity? Because, for example, in the Gulf, and I go there a lot, I found lots of doctors who are coming and saying, oh, fine, we're going to inject your pylorus with Botox, right? And then we're going to give you something else, and it does work. Right. How is it going to work? Yes, injecting the pylorus will kind of paralyze the pylorus, increase the gastric emptying. But we still have got a stomach that can easily accommodate a liter and a half of fluid or food. How are we going to lose the weight? And even if you think deeply into the problem, are you offering this to the Gulf patients who live on rice and sweets? How is this going to work? So I'm just a bit concerned about all of this, what's happening on the menu because I'm thinking that a lot of it is commercial. But the final, very tiny comment, and I mean it's tiny, I've learned over the years that never say no to any procedure, because you will have this one unique patient that comes probably once or twice a year, where all what you can offer him is an ESG, or all what you can offer him is a SASI, which is a strange operation, and you link a bit of the stomach to the pylorus of the a bit of bowel to the pylorus of the bowel. You will still find this odd patient where I can do a sleep, I can't give him GLP-1, I can do this, I can do this. So the only way I can help this patient is this operation, which maybe 6 months ago I've said it's rubbish. So I've learned to keep my mouth shut. Everything will be needed, but it's not going to be a standard practice. That's my view.
Thank you very much. Any other question? I would like to return to my initial question I posed at the beginning of the speech, and specifically I would like to ask if do you have any specific therapeutic algorithm when regarding to a patient, to a morbid obese patient, or do you talk with any patient individually? When do you start with medication and when not? Do you have any general recommendations as a take-home message for today?
I'll let Nicholas to go first and then comment on this.
Yes, in the era of new medications, you can start with them for a short time, but it's like to have a short period of lost weight and become to surgery with less complications. That's a concept. You can continue drugs, this medication, for a long term because it gives a better result overall. But afterwards, at some point, you have to stop it, and when you stop it, they lose their effect.
Okay, yeah. There is a clear recommendation in morbid obesity to use either semaglutide, I would say tirzepatide first, before surgery. Before surgery. This is in guidelines of ADA and the ESD consensus.
Yes.
So I think we should start with that.
Currently, what we're doing now, for example, in UCL, in the university, where we've come with a lot of the studies on the GLP-1 agonist and the surgeries and stuff. And actually, we are the official government referral center for complex problems. We had a meeting only a few months ago. It's the BOSS, which is the British Society of Surgery. Interestingly, following the meeting, BOSS has changed its name. And it has changed the name from British Society of Obesity Surgery to British Society of Obesity Medicine and Surgery. And it's on the medicine and surgery. So the name has changed to include the physicians, because we as surgeons have realized that there is no way that we're going to work without medicine. Right? I am someone, and I was telling this to Nikos, about 15 years ago, when I used to go to the British Society meeting, I used to say, in my personal view, I should not be seeing the patient first. The patient should come and see a physician, a dietitian, a psychologist, right, and a nurse. But the physician is going to make the decision, prepare the patients, and then they're going to send them to me to operate. Because I don't want to waste too much time in my clinic. I would rather waste the time in theater to operate. That has been resisted badly at that time. And I was being criticized, saying that you're not actually a true surgeon. Lastly, this year at the meeting, the highest physician in the UK who's dealing with obesity, Carl Leroux, reminded me about my views, and he was saying, Mohammed, we should not argue about who's going to treat the patient. Our view is we're going to treat obesity. And for me, I don't care if the patient loses weight with medicine, with lifestyle, with your surgery. All what really matters to me is that the patient has got rid of their diabetes or sleep apnea or infertility or . So I think what's happening now is just a combination, because we will see the patients who will come and say, I'm so scared of medicine, I would like to have the surgery, fine. Or another one who's going to come and say, oh, my cousin or my friend has died because of surgery complications, I'm not having this, so that will be treated there. In general, we cannot operate on very, very high BMI. So that's a patient who will start with my medical colleague to prepare them, and then we'll get. The ADA has recommended that any patients with uncontrolled diabetes with obesity should start GLP-1 agonist treatment, because that's the only way forward. Now, whether they come to surgery or not, it really depends. But what we have found also that we will find that there is about 10% to 15% failure with medications, either because of they cannot tolerate the side effects or their medication does not touch them. And this is when they will have to come to surgery. So for me, rather than arguing who's going to take these patients and will end up fighting, let every patient be seen by a physician. And if I get even the 10% who fail to lose weight by my physician colleague, I'll be doing much more than what I'm doing now. Yeah, that's how we see it.
Thank you very much for your excellent speeches and for the information you gave us. Thank you, Professor El-Galawi, for traveling here and coming to us. Thank you very much. Thank you very much for your attention and your seeing us, and we wish you a nice afternoon.